So, just a review of the liver. We know it's the largest gland of the body. One thing we know, it's very vascular. Okay? I have to remind you of that because as we progress with this discussion, the liver, that's what we're going to talk about, has a lot to do with a lot of things. So when it comes to very vascular, receives blood from the GI tract, portal vein, and from the hepatic artery. So when we're talking portal vein, we're also going to be talking about the portal hypertension. So we'll talk about that as we go along. So just a view, one little thing that is, of course, our liver being very vascular that has the front of the gallbladder. So it kind of peeks out there, of course, in all that world of good. Metabolic functions for the liver does many things. One thing that I want you guys to pay attention to is ammonia conversion. And that's going to be helpful when we go later on in discussions about cirrhosis of the liver. Because its one job is to convert the ammonia. If it doesn't, that's a problem. And then, of course, it does all this other stuff as well. But those are just reminders. When we're looking at our liver function tests, here's just to name a few. They also throw in a bilirubin. Really more popular too when it comes to pediatrics and kids, but also when patients become jaundice, right? And we'll talk about jaundice here a little more because you guys already know about it. Your prothrombin times, we know PTs for warfarin along with the INR, but with bleeding times, they will do a prothrombin time to see because we want to make sure that if the patient has liver disease, they're going to bleed. We need to check their bleeding times. And that's how we measure, one reason we measure our PT. Normally people just see it PT as warfarin and what the therapeutic range is. However, in this case, it's for a bleeding time. Cholesterol, we know that it is in charge of cholesterol as a whole too. So just some of the things that we can test wise, of course, is cholesterol levels. Additional studies, liver biopsies, ultrasound, CTs, and of course MRIs. So when we're talking about dysfunction of livers, the biggest and most common is our cirrhosis of the liver. When people think of cirrhosis, they automatically think of alcoholism. And it's not, it is true that cirrhosis happens with alcoholism. However, all the stuff that we mentioned earlier, or seen earlier, one thing is drug metabolism. It is responsible for metabolism of drugs. So patients that are on drugs, and I don't mean illegal drugs, I mean medication-wise, like chemotherapy, for example. Everything then metabolizes through that liver. So the stronger the med, the harder that liver's got to work. And eventually, it's going to get tired and cause disease, okay? And so that's one of the things we may see is this dysfunction could be cirrhosis from medication. So it goes on to say a couple more things, malnutrition, all of that kind of stuff. So when we're talking about manifest, just in general right now, specifically cirrhosis, when patients have liver disease, they are then jaundice, okay? Their eyes, the white of their eyes turns yellow, their skin turns yellow, and that shows us then our jaundice. Or suspicion that something is going on liver related because they're turning yellow. Then we have the portal hypertension, ascites. We all know that's fluid in the abdominal cavity. And then varices. Esophageal varices is what it should say in front of that, if you didn't know what a varices was. So what happens was the esophagus has a crack, and it causes frank red blood, because it's arterial blood, from the esophagus. So they vomit, literally, frank red blood from the esophageal varices. Then you have your hepatic encephalopathy. Encephalopathy has to do with ammonia, and we'll talk a little bit more than that in a bit. Coma could also result. And then the nutritional deficits. Multivitamins. So when you think of multivitamin, you think of the four, right? The water soluble and the fat solubles. A, D, E, and K. A, D, E, and K, that's four of them. And then B and C, when you think of multivitamin. So all six of those vitamins make up a multivitamin. A, D, E, and K, B and C. So when you're thinking about them as a whole, we mentioned A, for connective tissue, we didn't mention eyes. D, we think bone, right? Then we have E. What is E? We haven't mentioned E before. Skin. E is skin, and connective tissue goes along with that. K, we said clotting. B, all the B's in the world. Coordination is one. Energy is another. And then C, of course, preventing infection. So when they have that deficit, just think of all 6 of those things, well, more than 6 that we mentioned, but those things that we mentioned that they're deficit in. When we say, we just say, oh, multivitamin, but it's so much more than just a multivitamin. Folic acid is another vitamin deficiency. Folic acid as a whole. And that plays a big role in what cell? Red blood cells. So when you think red blood cells, you're thinking what? Oxygenation, right? Okay? You are now if you were. Okay? So oxygenation, right? When it comes to our folic acid, has a little bit to do with connective tissue as well, but bigger here, the red blood cell. Okay. So jaundice. Jaundice can be different types. I don't care if you guys memorize those or not. I just need you to remember jaundice. But probably the most important is the 2 that are most commonly associated with liver disease. It's probably what you need to remember. Okay? Is your hepatocellular and your obstructive. Is the ones that are seen more associated with liver disease as a whole. When we're talking about those 2 specifics, you'll see that may appear mild, then you see all these manifestations, clinical manifestations or signs and symptoms associated with it. Then obstructive, you have a change in urine color and in stool color if it is obstructive jaundice. And then patients itch. So our friendly itching. So if you have a patient with liver disease and they start scratching, it's just like we talked about with those renal patients. Now they have a risk for infection because due to their impaired skin integrity, right? So we don't want them to itch. If you see somebody with jaundice, they will be scratching. I can guarantee it. They will be scratching like crazy because it itches them. So that's something to keep in mind as well. Portal hypertension, obstructive blood flow through the liver. Increased pressure in the venous system, the portal venous system. That's what they have. Okay? If they have ascites and esophageal varices that I mentioned earlier, they have portal hypertension. They do, and they do. So, that ascites resulting from that increased blood flow in that venous system. One things that we need to do for them or needs to happen, or the movement of this into that. The assessment of them, we measure the girth, we find out how big. Keep in mind, when we say ascites, everyone's like, okay, fluid in the abdominal cavity, yeah, big deal. Think about it. That's like having that push-up, that full fluided, I just made a word, fluided belly, pushing up on that diaphragm. What's not happening is that diaphragm is not able to help. So what's going to end up happening? Shortness of breath is going to be one. What else? What comes along with shortness of breath? Exactly, impaired gas exchange. High five, yes. Because think about it, they're not able to take those deep breaths and work those alveoli. Okay? So impaired gas exchange. And that's all based on that fluid sitting there, not helping them, right? It's causing more harm than good for these patients. So if they can't take deep breaths and have impaired gas exchange, they're going to be hypoxic. Hypoxic comes what? Way too in-depth than what I'm thinking right now. Confusion. Hypoxia causes confusion. Now, with these patients that have confusion, some of the things that we can do to relieve these, so remember confusion in the back of your head for a second. Treatment of ascites. Here's everything we can do for them. Well, but in general, that will be done for them. So all of this works for that. Then it goes to a transjugular intrahepatic portal systematic, I know I say that funny, shunt. So now what they're doing is they're diverting that fluid from that portal system. And so there's not high pressure in that venous system. Okay, so it's shunting it away. And that's what the whole thing about our stent or shunt is in place. Okay? So, with that confusion, right, we mentioned, comes hepatic encephalopathy. So not only could they be confused from that fluid and that impaired gas exchange of being hypoxic, but they're also not converting ammonia. So if you've ever watched any sporting events, specifically football, they have those white things they break, they turn purple, they inhale them, they get everything aroused, and that's what happens with ammonia that way. For patients who can't convert ammonia, they're not getting aroused. They're getting confused, they're getting stuporous, and they're getting coma. So, for those who can't convert ammonia, because we, or those football players, can inhale that ammonia, they convert it, and they get aroused. These patients can't do that, okay? So that can lead them into bigger potential problems, seizure, stupor, coma, okay? What is one medication, if they're alert, I didn't say orientated, if they're confused, right? Alert enough to take, can we help get rid of that ammonia level? Or how do we get rid of ammonia levels? Lactulose. So we'll make them do what?
Poop it out.
Poop it out. We want them to poop, poop, and poop. So that tells you how we eliminate ammonia for these patients. They will release ammonia from diarrhea. Okay? Keeping in mind, right, what else are they going to be losing? Potassium, electrolytes, etc. Okay? So, management talks about lactulose to reduce, we already said, and all of these other type of things. Keep in mind, discontinuing sedative analgesics and tranquilizers. This is why they don't have that mechanism in the liver to convert or metabolize. So if they're already confused or stuporish, we give them sedatives or tranquilizers as a whole, being the same kind of drug. What are we going to cause them to do? Even be more, right? Because they're not going to be able to metabolize. So now it's drug toxicity that you just thrown into the mix. So of course, treating the complications and infection. So that is that hepatic dysfunction. So, couple things that I'm going to point out with hepatitis. We're not going to go in really great depth with these. Remember, itis for liver means either inflamed or infection. So there's many types, more common down the line as we speak. So when we're talking about viral hepatitis, here are the ones that are associated with viral. Non-viral hepatitis are those that are toxic or drug-induced. So those are those patients that get hepatitis, non-viral hepatitis, because what they've just done is called irritation to their liver by taking many of drugs. Now, non-viral is also those patients drug-induced with chemotherapy. Chemotherapy and MS drugs are the hardest on the liver. Not that any of them aren't hard, but those are just the ones that are harder on the liver as a whole. So we're going to go through these hepatitis. Viral hepatitis A. One thing to point out, all the manifestations that you're going to see, incubation times, please don't waste your time studying those. What you need to know is to know how you're going to prevent them and what do they look like clinical manifestations. So how do you prevent it? And then, of course, then, how are we going to recognize or things that they can tell you? So, for example, hepatitis A is fetal oral transmission. They need to wash their darn hands. Personal hygiene, okay, for A. Personal hygiene. Clinical manifestations, you're always going to see flu-like symptoms. Prevention, hand washing, vaccines, and then of course bed rest during the acute stage. And then nutritional support is going to be based on protein if their kidneys can handle it. Hepatitis B, transmitted through blood, saliva and semen, vaginal secretion, sexually transmitted. And then infant to the infant at birth. So transmission is interesting here. with the major cause, if you notice, major cause of cirrhosis, or liver cancers in the world. Again, flu-like symptoms because it's similar to A. Prevention, those that are healthcare workers or anybody at high risk, they would get vaccinated. Standard precautions and screening blood products, which it is less likely to get it for that reason, but you never know. Okay? Hepatitis C is the cause 1/3 of liver cancers in the world. These are candidates for liver transplants. The Judds, the mom, I always mixed up their names. Winona? Is that Winona or is that Naomi? Naomi, the one who just passed away. Do you know she was a nurse? And that's how she got hepatitis C? So years ago, before they had their sing career, I don't know in the time frame, maybe they came out singing after his kids. I don't know that whole timeline wise. But she was a nurse, got hepatitis C from working as a nurse. So one thing about it is risk factors associated with that would be us as healthcare providers. And then symptoms may be mild, but they get worse, and then of course cause chronic then liver disease. And hepatitis C, like I said, is the one that could be a liver transplant option for them. Hepatitis D and E. So hepatitis D is the patients, only the persons at risk are that have B, that are at risk for D. And then transmission is blood and sexual contact. Again, flu-like symptoms similar to B then. Then hepatitis E, fecal oral route. No chronic form, but it's fecal oral. So of course, hygiene, hand hygiene, things like that also play a major role in that. Other disorders we mentioned was the non-viral. Of course, toxic hepatitis is the exposure to the liver from toxins, chemicals, overdosing could also play a role in this world of overexposure to be toxic hepatitis. Patients will have anorexia, nausea, vomiting, jaundice, and a large liver, so hepatomegalia. The drug-induced hepatitis also could be a potential recipient of a liver transplant. If it's from acute liver failure, anesthesia can also play a role. Those meds we mentioned already, chemotherapy, if they can make it that long. I hate to say it like that, but MS drugs, rheumatoid drugs, and then acetaminophen. The last type of hepatic failure is a severely impaired liver function. They go quick from jaundice to encephalopathy. So getting back to cirrhosis as a whole, the alcoholic develops scar tissue on the liver. The post-necrotic has bands of necrotic tissue, and then the biliary is scarring, is what we see on the liver with these patients. So assessment-wise, as listed there, diagnoses are listed there for you as a whole, and then of course, clinical manifestations are some that we've seen already. But because of the cirrhosis, fluid volume excess when it comes to those patients that have ascites. So that's where that plays a role. So we've talked about that. Cancer of the liver. Normally, it's not common for it to, first region of cancer site is the liver. Very few cancers originate in the liver. If it does, it's hepatic cellular carcinoma, usually associated with B and C. So those patients who have been exposed to hepatitis B and hepatitis C. Right upper quadrant is your clinical manifestations. Another key point is the pain is a dull continuous ache in that right upper quadrant. So a dull continuous ache Jaundice, if the bile ducts are occluded, and then ascites from the portal veins. So then they would have portal hypertension as well. So non-surgical management of cancers, radiation, chemo, I'll mention there. Then surgical management, different types. They can do a lobectomy and then cryosurgery and or liver transplant surgery. So this is just a visual of the transplant surgery as a whole. A couple of things that you will see is many JP drains, and then you will also have a T-tube. And just what it says there, it's a duodenal drainage tube, also known as a T-tube. More than likely it would be a dark brown or dark green color, because it also is associated with bile. Alright, you guys doing okay, or you need a break? Break? No? We'll take a break when we do math review. How does that sound? Okay. Alright, just want to make sure you're okay. So when it comes to patients with